Welcome to State of Reform's virtual series, 5 Slides We're Discussing, with some of healthcare's most thoughtful leaders. And now, the host of State of Reform, DJ Wilson.
All right, well, welcome to this edition of 5 Slides We're Discussing. My name is DJ Wilson, one of the hosts here at State of Reform, bringing you these conversations, teeing up these topics, really bridging this gap between the world of health policy and the world of healthcare. And we're super excited to be with you all here. This is a North Carolina-centered conversation, but bringing in additional voices and perspectives from outside, from national figures. And of course, this is, as is always the case, meant to be an interactive conversation. So with the chat box here on the right of your screen, you can see an opportunity to chime in and to offer your 2 cents. And of course, when you post in that Q&A section, you can click the thumbs up icon and prioritize whatever comments or questions you want. We'll make sure we try to integrate those into our conversation today. So without further ado, let me jump into our introductions for our panelists. It's a good group. To start, we've got Robert Popovian, a senior fellow in health policy at the Progressive Policy Institute, Annette Guarisco-Fildes, good Lord, I did screw that up. I was trying not to, Fildes, President and CEO of the ERISA Industry Committee, and Andrea Reed, PharmD at Vice President of Pharmacy at Novant Health. Thank you, all of you, for being here. Annette, since I messed up your name, let me ask you first. Tell us what you're working on, what's commanding your attention these days.
Sure. So our association has been around for 40-odd years, and we represent large employers in every industry sector. And in the healthcare space, we do retirement also, but in the healthcare space, they care a lot about getting access to information so that their price and quality information, so that their employees can make really informed decisions about their healthcare. So that's top of mind for us, as well as costs that the companies are struggling with, since they pay 80% of the healthcare for the most part for their workforce. So lots of opportunities out there to make things better for families across the country.
Yeah, good stuff. Andrea, how about you? What do you spend your mental energy on?
Yeah, so my day job is leveraging automation, technology, and analytics to really provide innovative care models in our acute care facilities and improve our operational precision there. I also have another side of our team that I support that's focused on value and outcomes. So reducing clinical variation, controlling cost, improving the value, making sure that we're getting the expected outcomes of medications that we're paying for. But I'll tell you, most days are definitely taken up by responding to COVID surges, making sure that we're getting the monoclonals and the new oral agents for COVID management into the hands of our patients.
And give us a sense, Andrea, of the Novant footprint. Which states, how many physicians, et cetera?
Sure. Yep. I'll remove that from my overview on the slide. So we are a 4-state health system in the Southeast. We have 15 acute care facilities and 600 outpatient locations. So
not small. That's significant.
Very
Robert,
concentrated.
Yeah. Robert, how about you? Tell us about what's commanding your attention these days.
So I do most of my work in health policy and health policy research as it affects patients, consumers, employers, and the government. And my work is primarily done through the Progressive Policy Institute. I'm also a Chief Science Policy Officer at the Global Healthy Living Foundation, which is a patient organization. And I dabble in blockchain technology through Equidium Health, which is a company that works on trying to address the issue of health data transferability and everything else. And most of my work really, and my Twitter handle says it the best, I'm an advocate for consumers, patients, employers, and the government, because they're the true payers in the marketplace, not the insurers, not the pharmacy benefit managers and other kinds.
If Leonardo da Vinci were alive today, that Renaissance man, maybe he would also dabble in blockchain technology. I love that you are a Renaissance man. Robert, thanks for being with us. I appreciate it.
Thank you.
So the idea of this construct of this conversation is that as we all entered into COVID, of course, we all moved into this virtual space, and we wanted to continue having conversations like those that we had been teeing up before COVID. But in this virtual space, we wanted to also use the tools of the virtual space. And of course, those include multimedia and graphics. And so the framing and construct of this conversation today is that we've invited each of our guests to bring a slide with them so they can tee up one infographic, one data point, one sort of visualization of an issue that they want to really wrestle to the ground, and that we'll each spend a few minutes kind of chewing in or digging in and chewing on the graphic that is brought to the conversation. So we have 5 slides. We'll jump right in. Of course, our first slide is one that we have brought to the conversation, and I think the thing about this slide that I think is useful for us all is it shows folks, particularly those outside of the cost space, the relative price implications and the relative cost increases for different drugs, and specifically large molecule drugs like biologics you see at the top there, relative to smaller molecules, smaller medicine drugs down near the bottom, the average in between. So this conversation today is about trying to bend the RX cost curve, and that has had a lot of different framings and iterations over the last decade. But as we sit here today in the start of 2022, it seems to us that if we're going to try to get our hands around the ever-increasing cost of drugs, we're really talking about in significant part biologics, large molecules, and what will become sort of precision and personalized medicine. So Robert, let me ask you to start us off. When you see this slide, I wonder what your general thoughts are on how biologics fit specifically into the larger cost conversation.
Well, the data is what you're showing is absolutely true. The biologics, specialty medicines are what's driving increase in spending in the United States for pharmaceuticals, without a doubt. I mean, that's unquestionable. The question is it the utilization or is it the pricing issue? And it's a combination, and it's primarily the utilization. If you look at the data that's come out over the last 3-4 years from various sources, it will show you that it's what we're spending, why we're spending more on drugs in the United States is primarily being driven by utilization. So the question becomes, is that a good thing or a bad thing? Is it useful to have more utilization of pharmaceuticals and less utilization of hospitalization and office visits? Or do we need to address that issue as well? Is there inappropriate prescribing going on of these medicines? So those are all of the policy issues that come into play when you look at the data that you just presented, because clearly we need to have a better competitive marketplace for biologics and the larger molecules. And we are going to hopefully delve into that in the next few slides, looking into biosimilars.
So Andrea, as you think about this question about, is it utilization or is it price? And the reality, as Robert says, is that it's of course both, but how do you kind of try to wrestle with those competing? It's like having a foot in two canoes, like price might go this way, utilization might go this way. And the next thing you know, you're in kind of a world of hurt. How do you think about those two issues?
Yeah, I mean, I agree with Robert. I think we're constantly balancing both of them, right? Through our health system, we try to put in use criteria to make sure that we are using it appropriately, whether that's additional testing or, diagnostics or whatever it is, to make sure that that patient should be receiving that medication. But then in the end, also measuring those outcomes. That's a big part of why my role was developed, because if we're spending these tens of thousands of dollars annually for each patient, we're hoping that they're going to get those expected benefits of them. So we have a whole person just dedicated to doing pharmacoeconomic analysis and making sure that those achieved benefits are being received. On the flip side, when I get into my slide talking about the success that we've had in moving to biosimilars in our health system, that's been a significant cost savings for us and something that we continue to look at for other opportunities with contracting and interest in moving forward on value-based agreements. And in the future, partnering with payers and other organizations to align us all on the same page to use that same agent can result in additional savings for everyone.
And that it does not seem that long ago in my career where I remember ERISA, self-insured businesses, larger businesses really not having any handle on their pharmacy costs. But now they're not only getting a handle on pharmacy costs, but they're looking under the hood and differentiating by type of molecule or type of medicine. How are larger companies becoming more sophisticated in your view in 2022 versus maybe 2012?
Well, I think that these companies realize that, like Willie Sutton said, where you go where the money is, right? Why do you rob banks? Because that's where the money is. So they focus on their highest spend. They know that they have their patient population with comorbidities. They look at the drug spend per individual, and they look at what is troubling, and that is unreasonable utilization, either under or overutilization. As Andrea said, it's important for the prescribing to be accurate. And we see a lot of prescribing up, if you will. You go from a cream to an injectable. Is it necessarily better? Should we be starting with the injectable, or should we go back and start with the tried and true before we prescribe up? We also think it's important, and these companies have teams of people devoted to this. We have to look at the incentives, especially in the oncology space. Is a physician's incentive properly aligned with that of the patient? Does the physician make more money by prescribing and actually administering a biologic that costs more because they get paid a percentage of the cost, as opposed to prescribing something that's less costly for the patient and for the plan? I think there's lots of things to look at, and that's why these companies spend a lot of time and resources to make sure that we're getting it right. And when there's a public policy angle, that we fight for that as well.
Robert, I wonder if you have thoughts on Annette's comment about sort of the incentives. Like, why do you think some of this utilization may be inappropriate utilization?
Well, there's two reasons why we inappropriately utilize healthcare in the United States. One is the legal system. There's a huge, look, I'm a pharmacist. I've seen how physicians do a lot of prescribing or utilize health services because they're worried about the litigation that's going to come after that. There's no doubt about it. That's a lot of it. Some of it, not a lot of it, but some of it is driven through that. The second part is what I'm going to discuss in my slide is the misincentives in the marketplace. Annette alluded to it, that, sometimes prescribers, physicians make more money by administering certain drugs. The same is true by having certain insurers and pharmacy benefit managers making more money by covering certain drugs versus others, which creates misincentives in the marketplace. And that's what it's about. It's misaligned incentives in the market that driven a lot of inappropriate utilization. So it's a legal system that forces it, but also the not aligned incentives that we have in the current market that really drives inappropriate utilization. And that we need to get rid of, because those are the things that we can manage, and they're inappropriate spending. They don't benefit the patient. Like Andrea talked about, there is no benefit to the patient outcome for those things.
Andrea, why don't we turn now to your slide? Tell us the information and the graphics that you have brought to this conversation.
Yeah, thank you. So I really wanted to focus on how early adoption of biosimilars in health systems represents a significant financial savings opportunity. So at Novant Health, we've been on a several-year-long journey to educate and prepare our providers, our pharmacists, our leaders on all of the financial benefits of utilizing biosimilars as soon as they're available. So initially, there wasn't a big uptake. We didn't have a lot of support on the use of biosimilars. There was a lot of confusion around the products as they became available. And then the complexities within the operationalization and understanding when to use the originator versus the biosimilar based on patient characteristics and payer status. So as I mentioned, we at Novant Health are a $5.6 billion for state integrated delivery network in the Southeast, 15 acute care facilities. Most of those have infusion centers, and then the 600 outpatient locations. One huge benefit for us is that we have a single pharmacy and therapeutics committee that allows for aligned formulary decision-making. We have 4 pillars that we utilize to make those decisions. Those are safety, efficacy, clinical gap, and affordability. So adding that affordability in there really allowed us to prefer or integrate biosimilars into our formulary. Our biggest key to success initially was really getting the physician leadership buy-in. to not only support the use of biosimilars, but to say, hey, we are going to take a stand here and make these preferred. The next key to success was addition to the policy to say that we're not just going to add a biosimilar for that indication that it's approved for. We're going to use it for all FDA approved indications of the originator product. So extrapolating those indications for the most part was really helpful because we could use them in a lot wider range of indications. We did have obviously a few exceptions to that, like ophthalmology or pediatrics, where there were a little bit more concerns on the therapeutic benefits for those patients. And then our last keys to success were EMR operationalization with support of our IT team, but then also P&T committee support, allowing our pharmacists to make the interchange of all of those originator to biosimilars back and forth based on payer status. And so that's something that as a health system has been very hard to get our hands around, because those preferred products may change month to month, and they may change with very little notice, or we received the letter the week that we should have already been making that change. So we don't have the ability to take that through our P&T committee every single month to make that change. So instead, it's been something that our pharmacists manage it on the back end. So as you can see on this slide, this has been our 3-year journey. We've saved $14.8 million based on these 4 biosimilars, bevacizumab, trastuzumab, pegfilgrastim, and rituximab alone. So it's really clear in each graph where we were like, okay, here's the switch that we're making. We got, very quickly to up over 80-90% with each of the agents once that was done. The one drawback is that in many cases, we've had to have 1 to 3 of the biosimilars in addition to the originator product on formulary for the differences in payers. So that can be a struggle at times, but we maintain minimal products on the shelf so that we don't have a lot of costs there associated with that. Now that we've had success in this, though, it really allows us a way to leverage cost mitigation within the biologic space with payers. So that's kind of where we want to take our next conversations to. And it also allows us to then align those contracts better with manufacturers for some additional savings based on market share. So this, I think, is a great way that, if there's more uptake around this across the US, we'd see a lot better impact in the control of drug costs here in the biologic space.
And then I wonder what you make of this on behalf of employers. It feels like Andrea's story is both, it's exciting because you see, strategies playing out and the clear benefits, and at the same time hearing some of her frustration about the difficulty of keeping up and balancing all of these challenges. It seems like if a leading healthcare system can't always stay on top of this, it's even harder for employers, I would think, to be able to stay on top of this. What are your takeaways?
A couple of things. It's very exciting to see the numbers that Andrea shared with us. And they are really just the tip of the iceberg. Because what we see with costs is that as more and more, because we saw it with generics, right? As more and more generics then biosimilars can get on the market and compete with each other, we'll see lower savings across the board. And it's that level of competition that we really have to get to. We also, I think our companies struggle with a movement of folks from a biologic to a biosimilar. The kind of easier way to ease into it is to simply just start with new prescriptions. But when you have, especially the companies in the manufacturing sector, have lots of older workers who may have comorbidities, take a lot of medication, you don't want to be necessarily moving them, or the process to move them to a biosimilar from a biologic kind of takes a lot of time. But we see there's a lot of progress in this. I think it's just frustrating that we don't see more competition, because there are just ways for the brand manufacturers to still protect their market share, and rightly so. They have a lot of folks to report back to on that, and that's their interest, and we get that. But we try to do what we can to promote a robust, competitive marketplace for the biosimilars. But this is great stuff.
Robert, how about your takeaway from Andrea's slide? What are your reactions?
I can't stop smiling. I mean, this is exactly what should happen, right? In the marketplace for pharmaceuticals, Ian Reid, who was the former CEO, and I used to work for Ian at Pfizer, would always say we have a social responsibility that we have a certain period of time as pharma companies given time for us to make our money. And then after that, these drugs have to go become generics or biosimilars, and their value continues in perpetuity. It doesn't stop, right? These drugs don't lose their value just because, and he's absolutely right. And this is what needs to happen in the marketplace for us as a healthcare system to fight against government control and price controls. The biosimilars is a pro-private sector sort of solution to our pricing issues and our drug pricing and spending issues that the pharma companies and the government and everybody else should embrace, employers should embrace, and instead of going into sort of a government control, central control of drug price negotiation and everything else. So this is a solution that all pharma companies should be excited about instead of creating problems like misinformation and everything else that exists. So to me, I love what Andrea is doing in her institution, what Annette talked about, and it's just the tip of the iceberg. There are multiple institutions that are saving millions and millions of dollars by doing this, and this is how the system should work. And this is the societal responsibility that pharma companies have towards the engaging with what we want to do long term.
Let's take this opportunity to segue to your slide now, Robert. You've got some greater detail here in terms of some of the numbers. Why don't you walk us through what you have?
So my interest in discussing is the misaligned incentives in the marketplace currently that exist that really drive up healthcare expenditures for no other reason than profitability by what we call the supply chain or the middleman. And a couple of examples that I have is one, annually, a lot of pharmacy benefit management companies come out with their list of exclusionary formularies. They say we've excluded a certain number of drugs. And I just got doing a study in one of the PBM national formularies, and I'm just highlighting the one that is out there, which is Express Scripts. They put out, they basically exclude about 356 medicines from their formulary, which is fine. I mean, why are they excluding them? And this is the problem with the misaligned incentives created by rebate contracting. These are just three examples I have here on the left-hand side of the slide that demonstrate that in 3 occasions, the formulary for Express Scripts actually excludes less expensive authorized generics. So authorized generic, let me level the playing field. These are generics that are manufactured by the same brand company, same manufacturing facility, same bottling, same packaging. The only thing the difference is that they have a different NDC number. And in all 3 of these cases, these drugs are about 70+%, all the way to 200% less expensive in retail setting. And for some reason, they're excluded in favor of the brand drugs. And that's because it's of the rebate contracting. It's misaligned incentives. It doesn't make sense because we know not all of those rebates are going to flow back to the patient or to the employer or to the government. So this is misaligned incentives. This is just 3 examples. There's multiple other examples within this formulary right now that's been constructed by Express Scripts. Now I want to move on to the other thing, which is why are we not paying cash for certain medicines in the marketplace? So this is a study that I was sort of involved in with the Schaefer Institute. I was able to put Schaefer with Costco to do this study. So what Schaefer Institute did is that they looked at Medicare data over a 2-year period. And they said, what happened if Medicare, instead of reimbursing PBMs for the top 200 generics, went and paid cash for the same time period and purchased the medicines in cash from Costco? And what they found out is that over a 2-year period, Medicare would have saved $4.5 billion. In other words, it would have been cheaper for the federal government to buy membership for Costco for all the Medicare patients and have them go pay for it in cash and then reimburse those individuals than it is to go through the insurance model, which is inherently the wrong incentive because you always think that you use your insurance, you're going to get the best deal. And these are just 2 examples where the insurance model creates misaligned incentives, whether it's through rebate contracting and not having a good cash marketplace or incentivizing a good competitive cash marketplace, where employers and everybody else in the health system can save a lot of money. and the patients can save a lot of money. So again, we need to align incentives in the market, and this is just two examples of where the market fails currently.
Andrea, how do you see these misaligned incentives, as Robert puts it, play out as you're trying to manage utilization in Avant?
Yeah, so I mean, this makes me think of when we have opportunities for like bulk buys, right? Because he's right, we do get lower pricing in those situations if we do a bulk buy certain times of the year, getting that discount from the manufacturer up front, as opposed to, just waiting on our rebate or contracts that we already have in place where we get those rebates back later in the year. So I totally agree with the concept. Interesting to see how, that plays out in different settings, health system versus in insurers.
And Annette, do your employers feel like they are on the outside of this formulary setting and exclusionary practice, sort of on the outside looking in, or do they feel like they have real capacity to impact formularies because of their ERISA status?
Well, they have a lot of ability to do a lot, but there's only so much plan design can do because they're not purchasing the medications directly. As long as they're using a PBM, they're having to deal with this frustrating process about using rebates. And we agree with Robert completely that it was, from our perspective, rebates belong to the plan. The plan is buying the medications on behalf of the employees. Rebates belong to the plan so they can pass through the savings in reduced premiums to the plan participants, not giving them back at the point of sale, because that doesn't take into account that the employer is providing coverage to a wide swath of individuals. But we think that we need to shed some sunlight on the PBM process. We are supportive of the PBM transparency legislation that we were hoping to get done in the budget reconciliation bill, and we're still pushing hard for it because we think that there's not enough information so that we can't really see how much we're spending, and neither can patients. So it's an area that's ripe for reform.
Is the PBM space a space that employers feel like they can move into as a cooperative? I think of things like Civica RX, which is an enterprise led by, in many cases, hospitals like Intermountain and Providence and others, to produce generics that they can then purchase for their and other medicines for their health systems. I wonder if employers might be thinking about building cooperative models in the PBM space, or if that's just like too far afield from their primary job, which is running their business.
Right. There's a lot of struggle with that. I mean, we make widgets, we sell services. That's where we should be focused, and not creating these entities through which we could provide an employee benefit. We rely upon the PBMs to be our trusted partners. But companies are involved in cooperative organizations across the country to try to see if they could move the needle and cut do some direct contracting and cut the PBMs out of the process. It depends a lot on the industry, the particular employer, what their pain level is in this area. But they've tasked us with getting legislation when they can't do it themselves. In their own marketplace and their own contracting relationships, they call upon us to ask Congress to get something done. And it's not dissimilar from when we had to ask Congress to ensure that claims data would belong to the plan sponsor. I mean, heaven help us, they're the plan beneficiaries. We've paid all the claims. It's our data, and we shouldn't have to pay an insurance company to get it back for our plan beneficiaries. So yeah, same sort of thing.
I'm reminded of the initiative by Amazon and Berkshire and JP Morgan to fix healthcare that had so much buzz and then dissolved a few years later. And now I want to turn now to your slide. I know you've got some additional content here building on your comments. So walk us through what you've brought to the conversation.
Okay, Robert, did you have a point though you wanted to make?
Yeah, I wanted to make a point. I mean, one of the things that I get frustrated about, and whether it's the federal government, the state government, or the large employers is that they don't have audit rights of the PBM book. I mean, I just don't understand this. And this is the one place, DJ, if you want to start off, let's put aside everything else. We should just have employers, the federal government, state government should have audit rights of these PBM ledgers. And I can tell you that will resolve a lot of the issues because that will shed transparency. And for some bizarre reason, we just don't have that.
Is that a policy? Is that a policy that the Progressive Policy Institute has been pushing?
We've always pushed about transparency. I think transparency resolves a lot of the issues, and part of the transparency is having PBM, not the PBMs, but the federal government and the employers and the state government to have audit rights of these books. There is no audit rights. There is no third party even verifying some of this data that the employers and federal government and state government gets back from the PBMs. There is no KPMG or somebody in the middle even auditing these things.
Mm-hmm.
So middlemen, we need that. We need this in the marketplace desperately. And that's where we start with better data to make better decisions.
Thank you for making sure Robert brought that to the conversation. Let's take a crack at your slide now.
Okay, so my slide focuses on the savings that patients, plan sponsors, and the federal government programs can save with biosimilars. The numbers from our study is based on real data from our member companies. The numbers are quite staggering because they show savings with just 2 biosimilar medications. So let me share a bit about kind of why the study, kind of how we did it and why we got to where we are. So as I said earlier, we're an advocacy organization. So we're lobbying all day, every day for rules and regulations to help our companies be able to provide these great benefits to their workforce with a minimal amount of compliance burdens, state by state record keeping rules, for example, things like that, and a lot of transparency. And since we're the only association that does what we do, because we represent exclusively large plan sponsors, we're really busy, right? But our member companies, they said to us, we're hearing a lot about biosimilars. Remember, this is back a couple of years. We're hearing a lot about biosimilars, but is there real opportunity for savings? So when we talk with them, no matter what they're in the banking industry or retail or energy or technology, manufacturing, you name it, they're struggling with skyrocketing prescription drug costs, and they focused on specialty medications, as we said at the earliest point in this presentation today. There's enormous pressure on their budgets and on household budgets to pay for these specialty medications. So with a focus on innovation and competition, as we said earlier, we waited for generics 10 years, more than 10 years from the ACA, when the pathway for biosimilar medications was put into law to allow the FDA to even do it. We're waiting a really long time, right? So we teamed with Johns Hopkins to really drill down, and this was first of its kind research. So we actually looked at their actual spend for these 13 companies in different industries. We drilled down on how much they would spend per company and on average. And then we studied, and we could talk about these numbers in a minute, then we studied what the plan sponsors can do on their own with, could they do plan design changes? Could they communicate better? Can they help educate their employees and the like? And then we did a list of public policy recommendations, which I hope we'll get to later too, like what Congress can do to remove the impediments to access and availability of biosimilar medications for the workforce. So hope that helps.
And I wonder if you could highlight a couple of public policy solutions that your ERISA committee is advocating for in Congress.
Sure. So we are in favor of the ADAPT Act, for example, which is legislation that would fast track at the FDA approval of biosimilar medications if they've already been approved by the European Union, which, as you all know, is ahead of us in approving biosimilars, generally speaking, and they just are faster doing it as it is. So, working with the company to be able to expedite the process, we think that would get a lot more biosimilars onto the marketplace. We've got legislation that we're supporting to prevent the pay for delay agreements, where a brand and a generics or biosimilars manufacturer will will have a side agreement that prevents the biosimilar from getting to the marketplace. So there may be savings for the company, but it's not savings for the plan sponsor or the patient. And there are legislations called the Stop Stalling Act and the Ensuring Timely Access to Generics Act, which address the citizens' petitions that will slow the process of the FDA. We've also asked that the FDA get more examiners and more staff so that they could approve. They just need to focus on the drugs that will save most lives, that would address the most pressing healthcare needs, get more people hired by the FDA to get the approval process to speed up. Just some of them. We've got a whole long list on our eric.org website.
Yeah, great. Robert, how about you? Any of those public policy options that Annette has just teed up that you want to amplify, or others that you want to add as suggestions?
So I would say a few things to add, which is we need to create incentives in the market, the right market incentives, right? So for example, how would we incentivize physicians to basically prescribe these things? Because Annette alluded to it, they make less money if they prescribe a biosimilar versus a originated biologic. Well, there's one way is to share the cost savings with them, perhaps giving extra money to them to be able to incentivize them to do that. The other thing is perhaps having lower tier for out-of-pocket costs for biosimilars versus the originator biologics, having the patient benefit from using a biosimilar instead of biologic. But one of the things I want to go back to the FDA. FDA has done a great job of educating about biosimilars. There's a lot of good educational material, but they're also dragged their feet on a few other issues, and that alluded to about the biosimilars that have delayed this issue. One is providing guidance in a lot of the different policy topics that they've sort of like left it open. They haven't really finalized the guidance, and it's created a lot of misinformation in the marketplace. And they also need to do a better job of tramping down and hammering the pharma companies or any other entities that are out there that are providing misinformation about biosimilars. They haven't gone after those individuals aggressively, and they should do that because there's a lot of misinformation out there that is not being addressed.
Andrea, I wonder how you see these policy conversations impact your day-to-day. I mean, I assume you don't spend too much time on policy. Maybe you do, and you can correct me, but I assume that you are often trying to educate that the world in which you live is ahead of the world of policymakers, and that the policymaking community needs to catch up. Are any of those assumptions accurate?
In some ways it's true, but in some ways it is a barrier. I mean, the fact that it isn't clear and the fact that it did create a lot of confusion for physicians. And there is a lot of opportunities with aligning those incentives, as Robert says. So it's not on my mind day to day, but we do look at it regularly. We have a government affairs team that does keep us updated. And as any of those policies come through on their radar, they bring them to us to make comments or make sure that they're either advocating or we can advocate on our behalf. We particularly engage a lot in the 340B space because that is such an impact to health systems, but certainly see lots of opportunities for us to continue to engage here, and something I would like to take back for conversation to that team. I also see opportunities from Annette's slide in that in our health system, we have a whole team in corporate health, and I don't engage with them regularly that could help provide better support for the employers to help align those things and help them navigate through the biosimilars.
Yeah,
So,
there's crossover sometimes when we least expect it. We're all so busy working in our silo, right?
that's right.
I want to ask sort of each of you this question about personalized medicine. Biologics are not necessarily personalized medicine, but because they are larger, they are sometimes more specific to individuals or to more complicated and rare disease states. We can step even farther into things like gene therapy and other truly personalized medicine. I think as we move into that space, we will have, and as we see with biologics, we have more miracle cures happen and more amazing healthcare outcomes happen. And yet that likely will lead us towards more expensive treatments and services that are being delivered. In other words, personalized medicine is more miraculous and more expensive, and will create more of these public policy options that we're talking, or hurdles and challenges that we're talking about. Does personalized medicine give you sort of concern and consternation because of the policy implications? Any of you, setting aside the miracles that they bring in terms of health outcomes? Robert, do you have any thoughts on
yeah,
this?
let me start. I mean, precision medicine has been around a long time. We've had precision medicine drugs for the treatment of cancers or any other type of medicines that are precision related for a while. The difficulty is going to be what you alluded to, DJ, which is the cell and gene therapies that are coming on board. These are different, right? These therapies, you're not going to see the outcome for years down the line. And the current model that we have for reimbursing for these medicines, whether it's through pharmacy benefit management companies, insurers, whoever you want to talk about, health systems, it just doesn't work for these new therapies. We need a brand new type of a reimbursement model, financing model, to be able to address this issue. And the reason being is unfair, and this is where you're never going to hear me say this, this is unfair for an insurer or a pharmacy benefit manager to pay for these things, because the patient moves on, right, regularly from one insurer to the next, or the pharmacy benefit management company. Same with employers. Employers should not be on the hook, because frankly, they may not be employed by that employer. So why should they take on the risk? And same thing applies to health systems. Health systems, patient moves on from one health system to another. We just don't have the current model infrastructure in place from a financing standpoint that is going to be able to pay for these new miracle drugs, like you alluded to, DJ, these cell and gene therapies. And we need to develop one, and we need to develop one quickly, because they're coming on, and they're coming on like a tsunami, and they're going to hit the marketplace within the next 5 years with multiple gene therapy and cell therapies that are going to provide absolutely game-changing cures for patients. But at the same time, patients going to have to, you have to basically follow the patient for 30, 40, 50 years, depending on type of gene and cell therapy.
Andrew or Annette, do you have any thoughts on this?
Yeah, I mean, we're deep into the CAR T, and it's a very manual process to manage that. We've got to get everybody aligned and ready each time we have a patient, and really got to closely monitor their outcomes, and those financials are, that's just going to take a whole facility one patient. But then, not even at the cellular therapies, there's a lot of new therapies that are coming out that are for very rare disease states that we might only have 2 that have even been diagnosed in our entire footprint. It's like, well, that doesn't really follow our 80-20 model of adding these drugs to formulary. You can't just leave them sitting out there. These are going to save people's lives, and you've got to figure out how to manage that financially, make sure that patient gets the drugs, and see what those outcomes are. So we have a whole list of those right now that we're probably going to have a whole subcommittee of our P&T just dedicated to working through those, and a finance group that works alongside of all of us clinicians to monitor all the outcomes.
Yeah. I know we have one slide left, and I want to just tee this up. I think this is one that shows in very simple terms the impact of biosimilar competition on that biologic line of business. You can see here price of biosimilars in Q1 of 2021 and how it is different than the biologic comparable medicine. These are similar numbers that we saw from Andrea's slide. This is, of course, nationwide as compared to her system, but it retells the same story, and I think is just puts this conversation in really stark terms. I wonder, as we near the end of our conversation here, as you look out onto 2022, each of you, and sort of think about the cost pressure of these of biologic and large medicines, gene therapy, and the miracle opportunities, and all of the moving parts of policy and market activity, and what gives you hope as you look out onto 2022 and the work ahead? And that what gets you out of bed in the morning to do this work every day?
Well, I'd say is that because I started in this business almost 40 years ago, I have a hope that bipartisanship will come back. I worked up on the Hill and in the administration at a time when people worked across the aisle and were cooperative with each other. They didn't get all they wanted, but they did work together. And I am, hopeful that day will come again, where people will be able to work together, because these problems are too big for any one party to solve on their own. We all want people to be healthy and to get the medicines and the treatments that they need. But it's a zero-sum game. So if someone's going to be paid more for something, then someone's going to be paid less because we don't have new money to throw at it. And I think that's the biggest challenge. And the only thing that will help it is a bipartisan effort. So that's what I'm hopeful for.
It is amazing just listening to you talk there, and that 2020, 2021, 2022, and the lack of bipartisanship today can make the 1990s look like a bipartisan era. That was not a bipartisan era, and yet it looks good by today's standards. Andrea, how about you? What gives you hope as you look out on 2022?
Yeah, I mean, the clinician in me is excited about the new therapies, right? And life-saving medications that are coming out, impacting patients' lives. The health system leader in me is excited, to continue to drive some of these savings or control costs, because we know it's the drug costs are exceeding the medical costs. And then really the person in me gets excited about the health equity piece. So as we're doing all of this, we're talking about the people that have insurance or, can access these therapies, but there's a whole group of people that we haven't even mentioned on this call, which don't even have access to those medications. So that has to be part of our considerations throughout all of this as well.
Robert, 2022 lies ahead. What gives you hope about the road ahead of us?
People like Annette and Andrea give me hope, because frankly, they're the ones that, are in the middle of either providing the healthcare or financing the healthcare, which are the two important parts of providing care for patients. And patients gives me hope. But the most important thing is that we're asking the right questions finally. I think 5 years ago, if I had this conversation about transparency, it was just screaming at the ocean and the waves. Nobody would listen. Nobody cared. I think people are asking the right questions. And the more transparency we have in this system, the better we will all be off. Pharma companies, insurers, pharmacy benefit managers, but most importantly, employers, patients, and the government, which are the true payers of the healthcare system.
Robert Popovian, Senior Fellow for Health Policy at the Progressive Policy Institute. Annette Guarisco-Fildes, President and CEO of the ERISA Industry Committee, and Andrea Reed, the Vice President of Pharmacy at Novant Health. Thanks for making time to be with us. And for our attendees, I see Paul Kelly and Anita Stanford and Susan Huffman and Jessica Hatton and Louis Thorpe and a bunch of other folks with us. Thank you very much for being here. We'll have this recorded and up on our site at stateofreform.com. Appreciate all of your support. Thanks, everyone.